Prevention of ICU-acquired complications. Why this topic matters. Admission to the ICU should be a bridge to recovery, not the beginning of a new set of complications. Yet, evidence shows that up to 40% of our patients develop preventable ICU-acquired complications, from ventilator-associated pneumonia and catheter-related infections, to ICU-acquired weakness, delirium, and malnutrition. These complications prolong ICU stay, increase mortality, increase cost of care, and rob patients of functional recovery long after discharge. This presentation is not about high-end technology. It is about going back to the basics that save lives. Prevention of ICU-acquired complications is built on 5 simple but powerful pillars: rigorous infection prevention, meticulous respiratory care, early mobilization, delirium prevention, and timely nutrition support. Each pillar is anchored in safety, standardized protocols, and truly patient-centered care. Our goal today is practical: to focus on adult ICU patients, adapt global evidence to our local protocols, and tailor interventions to individual patient risk factors, age, severity of illness, immune status, and nutrition. Because in the ICU, safer care is better care, and better care means better outcomes. Prevention of ICU-acquired complications. Clinical presentation. Adult ICU focus. Adapt to local protocols and patient factors. From rescue to reliable prevention, a practical, bundle-based approach to reducing avoidable harm in the ICU. For years, ICU care focused on rescuing patients from complications after they occurred. The shift now is toward reliable, proactive prevention. By using evidence-based bundles consistently, we can reduce avoidable harm, shorten ICU stay, and improve both survival and functional recovery. Learning objectives. 1. Define common ICU-acquired complications and their mechanisms. 2. Apply evidence-informed prevention bundles at the bedside. 3. Integrate infection prevention, liberation from ventilation, mobility, nutrition and skin care. 4. Build measurement, escalation and feedback into routine ICU practice. Why prevention matters. 1. ICU patients are exposed to immobility, invasive devices, sedatives, sleep disruption, malnutrition and antimicrobial pressure. 2. Complications interact. Delirium can delay extubation. Immobility worsens weakness and pressure injury. Devices create infection risk. 3. Prevention is a system property. Reliable processes, teamwork, surveillance and patient-family engagement. 4. Use daily goals rather than isolated checklists. Each patient in the ICU rarely occurs alone. One problem triggers another, creating a cycle of prolonged ventilation, infection, weakness and longer stay. Prevention works only when the whole team follows reliable, daily processes instead of relying on individual memory. The complication map. 1. Infectious. CLABSI, COTI, VAP-VA, antimicrobial-associated diarrhea and resistant organisms. This is due to invasive devices and broad-spectrum antibiotics that break natural barriers and select for resistant pathogens. 2. Neurologic functional. Pain, overstation, delirium, ICU-acquired weakness and post-intensive care syndrome. This is due to prolonged sedation, immobility and sleep disruption that impair brain and muscle function. 3. Respiratory cardiovascular. Ventilator-induced injury, atelectasis, thromboembolism and unplanned extubation. This is due to positive pressure ventilation, immobility and inadequate liberation practices that injure lungs and promote clot formation. 4. Skin, nutrition, pressure injury, device-related injury, glycemic problems, constipation and refeeding complications. This is due to pressure, moisture, poor perfusion and delayed or inappropriate nutrition that breaks down skin and metabolic balance. The daily safety huddle. 1. Confirm diagnosis, goals of care, airway, ventilator plan and hemodynamic targets. This ensures everyone on the team is working toward the same clinical goals and avoids conflicting plans. 2. Ask, what can be removed to line, urinary catheter, infusion, restraint, sedation or ventilator support. This reduces exposure to invasive devices and drugs, which are the main drivers of infection, delirium and weakness. 3. Review pain, RAS, delirium, motility, nutrition, bowel function and skin device sites. This captures all high-risk complication areas in one routine check so nothing is missed. 4. Assign an owner and deadline for every prevention action. This creates clear accountability and ensures preventive tasks actually completed, not just discussed. ABSIDEF ICU Liberation Bundle. Assess, prevent and manage pain. This is because uncontrolled pain increases agitation, sympathetic stress and risk of delirium, while overtreatment causes overstation. B. Both spontaneous awakening trials and spontaneous breathing trials when safe. This is to shorten time on the ventilator and reduce ventilator-associated complications and weakness. C. Choice of analgesia and sedation. Target the lightest effective sedation. This keeps the patient more awake and interactive, which reduces delirium, shortens ventilation time and allows early mobility. D. Delirium. Assess, prevent and manage. This is because delirium is linked to higher mortality, longer ICU stay and long-term cognitive impairment. E. Early mobility exercise. This prevents ICU-acquired weakness, improves lung function and helps maintain functional independence. F. Family engagement and empowerment. This improves communication, supports reorientation, reduces anxiety for patient and family, helps with recovery goals. Hand hygiene and standard precautions. 1. Perform hand hygiene at the WHO 5 moments. Before patient contact, before aseptic procedure, after body fluid exposure, after patient contact, after touching surroundings. This is because hands are the most common transmitting organisms in the ICU. 2. Use alcohol-based hand rub when hands are not visibly soiled. Use soap and water when indicated by local policy or visible contamination. This ensures effective removal of organisms, especially spores, while keeping compliance at the bedside. 3. Use aseptic non-touch technique for invasive procedures and medication preparation. This prevents direct contamination of sterile sites and infusion systems during device handling. 4. Audit compliance. Provide immediate feedback and ensure supply available at the point of care. This sustains good practice by making it easy to do the right thing and correcting gaps in real time. Device stewardship. Insert only when needed. 1. Every device has a daily indication: central line, arterial line, urinary catheter, airway, drains and feeding access. This is because any device left in place without need increases infection, thrombosis and skin injury risk. 2. Use the least invasive option that meets the clinical need. This reduces trauma, infection risk and patient discomfort while still achieving the therapeutic goal. 3. Document indication, insertion date, maintenance plan and removal. This provides visibility on device age and helps the team know when removal or replacement should be considered. 4. Include device necessity in rounds and handover, not only at insertion. This ensures daily review and prompt removal, so devices are not forgotten during shift changes. CLABSI prevention. Insertion. 1. Avoid unnecessary central venous access. Use ultrasound when appropriate and trained. This reduces failed attempts, vessel injury and risk of introducing infection. 2. Maximal sterile barrier precautions. AP, mask, sterile gown, sterile gloves and full body drape. This creates a sterile field that minimizes contamination during insertion. 3. Prepare skin with alcoholic chlorhexidine unless contraindicated. Allow it to dry. This kills skin flora effectively. The effect is lost if it does not dry completely. 4. Choose the optimal site and use a standardized insertion checklist with an observer empowered to stop the procedure. This ensures best practice is followed every time and unsafe breaks in technique are corrected immediately. CLABSI prevention. Maintenance. 1. Hand hygiene and aseptic access every time. Scrub the hub using the product and duration specified locally. This is because the hub is a common entry point for organisms if not disinfected properly before each access. 2. Maintain a closed, intact dressing. Replace if damp, loose, visibly soiled or according to policy. This protects the insertion site from external contamination and allows early detection of infection signs. 3. Disinfect connectors and minimize line breaks. This reduces interluminal contamination, as each opening of the system introduces a chance for bacteria to enter. 4. Review necessity daily. Remove promptly when no longer essential. This lowers exposure time, and shorter dwell time directly reduces the risk of bloodstream infection. VAP prevention. Airway bundle. 1. Avoid intubation when a safe alternative is appropriate. Reassess readiness to liberate daily. This is because each additional day on the ventilator increases the risk of pneumonia and lung injury. 2. Head of bed elevation, usually 30 to 45 degrees, unless contraindicated. This reduces aspiration of oropharyngeal secretions into the lower airway. 3. Oral care with toothbrushing and secretion management. Follow local antiseptic policy. This lowers bacterial colonization in the mouth that can be aspirated into the lungs. 4. Minimize sedation. Prevent aspiration. Use appropriate cuff pressure monitoring and maintain ventilator circuit integrity. This keeps protective reflexes, prevents leakage around the tube and avoids unnecessary contamination circuit. 5. Do not change circuits routinely without clinical indication. This is because frequent circuit changes increase disconnections and infection risk without added benefit. Ventilator liberation. 1. Use protocolized SAT/SBT screening with clear safety exclusions. This ensures every eligible patient is assessed daily in a safe and consistent way for readiness to come off the ventilator. 2. Coordinate sedation reduction with respiratory assessment and analgesia. This avoids agitation from uncontrolled pain and allows a more accurate assessment of breathing effort. 3. Assess cough, secretion burden, airway protection and post-extubation risk, not only the SBT result. This is because past breathing trial does not guarantee the patient can protect the airway and clear secretions after extubation. 4. Plan extubation support. Oxygen, high-flow oxygen or non-invasive ventilation when indicated. This provides targeted support for high-risk patients and reduces the chance of reintubation. 5. Prevent unplanned extubation through appropriate fixation, communication and observation. This reduces airway injury, aspiration and emergency reintubation from accidental tube removal. CAUTI prevention. 1. Avoid urinary catheterization for convenience or incontinence management. This is because any unnecessary catheter is an unnecessary infection risk and alternatives should be used where possible. 2. Use aseptic insertion. Sterile equipment adhere the catheter without traction. This reduces trauma and introduction of organisms during insertion and prevents irritation and injury during care. 3. Maintain a closed drainage system, unobstructed flow and a bag below bladder level. This prevents backflow of contaminated into the bladder and avoids breaks in the sterile system. 4. Perform needle care according to local policy. Avoid routine antimicrobial irrigation. This keeps the area clean without causing irritation or encouraging resistance from unnecessary antimicrobials. 5. Daily necessity review. Nurse-driven removal protocols can improve reliability. This ensures prompt removal when no longer needed, and empowering bedside nurses makes daily review happen consistently. Antimicrobial stewardship. 1. Obtain appropriate cultures before antibiotics when this will not delay treatment in sepsis. This helps identify the causative organism and guide targeted therapy without delaying urgent treatment. 2. Use local antibiograms and specific risk factors to guide empiric therapy. This improves the chance of covering the likely pathogens while avoiding overly broad or ineffective choices. 3. Perform a 48 to 72-hour antibiotic timeout. Indication, cultures, spectrum, dose and duration. This creates a structured opportunity to reassess if antibiotics are still needed and correct the regimen. 4. De-escalate. Stop or switch to enteral therapy when clinically appropriate. This reduces exposure to broad-spectrum agents, lowers toxicity resistance pressure, and speeds recovery. 5. Use infection prevention measures to reduce the need for antibiotics. This is because preventing infections in the first place is the most effective way to reduce antibiotic use. Pain, sedation and delirium. 1. Assess pain routinely. Self-report when possible. Validated behavioral tools when not. This ensures pain is not missed in patients who cannot communicate and allows timely treatment. 2. Treat pain before escalating sedatives. Use multimodal and non-pharmacologic measures. This is because pain is often the underlying cause of agitation and treating it reduces unnecessary sedation. 3. Set an individualized RAS target and reassess after every intervention. This keeps sedation tailored clinical goal and prevents both oversedation and undersedation. 4. Screen delirium at least once per shift using CAM-ICU or ICD-SC, and correct reversible causes. This allows early detection of delirium, as routine screening picks up cases that are easily missed clinically. 5. Avoid routine pharmacologic delirium prophylaxis. Prioritize multi-component prevention. This is because drugs have not shown benefit for prevention and non-pharmacologic strategies are safer and more effective. Delirium Prevention Bundle. 1. Reorient. Clock, calendar, explanation and consistent communication. This helps maintain awareness of time, place and situation and reduces confusion. 2. Correct sensory impairment. Glasses, hearing aids and appropriate lighting. This improves interaction with the environment, as poor vision and hearing worsen disorientation. 3. Protect sleep. Reduce noise, light, cluster care and avoid unnecessary overnight disruption. This preserves the normal sleep-wake cycle, which is critical cognitive function. 4. Treat pain, hypoxemia, infection, withdrawal, retention, constipation and metabolic abnormalities. This addresses common reversible triggers that can precipitate or worsen delirium. 5. Mobilize early and reduce exposure to deliriogenic drugs where clinically feasible. This supports brain function and reduces the impact of medications known to contribute to delirium. Early mobility and ICU-acquired weakness. 1. Assess readiness, hemodynamic, respiratory and neurologic stability, check lines, drains and weight-bearing limits. This ensures mobilization is safe and prevents adverse events or dislodgement of devices. 2. Progress, passive range of motion right pointing arrow active exercise right pointing arrow sitting right pointing arrow standing right pointing arrow marching right pointing arrow ambulation. This provides a graded approach that builds strength step by step according to tolerance. 3. Use trained team, appropriate equipment and stop criteria for deterioration. This promotes safety and consistency, and allows early identification of intolerance during mobility. 4. Minimize deep sedation, immobility and unnecessary neuromuscular blockade. This is because prolonged sedation and immobility are major contributors to muscle wasting and weakness. 5. Continue rehabilitation planning through ward transfer and discharge. This maintains functional gains and supports recovery beyond the ICU stay. Sleep and environmental design. 1. Differentiate day and night with light, orientation and activity. This helps restore the natural circadian rhythm and improves orientation and sleep quality. 2. Cluster procedures, reduce alarms and use quiet hours where safe. This minimizes unnecessary interruptions and creates protected time for sleep. 3. Offer eye masks and earplugs when suitable. Address pain and dyspnea first. This reduces environmental stimuli, while controlling pain and breathlessness is essential before sleep can occur. 4. Review medications that disrupt sleep and avoid routine nocturnal blood tests when unnecessary. This is because some drugs and frequent nighttime interventions fragment sleep and delay recovery. 5. Family presence can support orientation and reassurance. This provides familiarity and comfort, which reduces anxiety and helps maintain a sense of reality. Nutrition and aspiration prevention. 1. Screen nutrition risk early and involve dietetics. This allows early identification of malnutrition and ensures a tailored feeding plan. 2. When feasible, initiate enteral nutrition within 24 to 48 hours after ICU admission once hemodynamics are sufficiently stable. This supports gut integrity, reduces infection risk and improves outcomes compared to delayed feeding. 3. Advance cautiously, monitor intolerance, aspiration risk, electrolytes and refeeding syndrome. This ensures safe progression of feeds while detecting complications early. 4. Use head-up positioning, verify feeding access and follow local tube placement policy. This reduces the risk of aspiration and confirms the tube is safely placed before feeding. 5. Both underfeeding and uncontrolled overfeeding. Reassess with clinical trajectory. This maintains adequate energy balance, as both extremes worsen morbidity and recovery. Pressure injury prevention. 1. Risk assess on admission and after major clinical changes. Inspect skin at least daily and device interfaces each shift. This allows early detection of at-risk patients and pressure damage, especially in areas hidden by devices. 2. Reposition according to individualized risk, tissue tolerance and support surface, not a rigid interval alone. This ensures repositioning is tailored to patient need, as fixed schedules may not prevent injury in high-risk patients. 3. Offload heels and protect occiput, sacrum, ears, nose and areas under devices. This is because bony prominences and device pressure points are most vulnerable to pressure injury. 4. Use pressure redistributing surfaces and manage moisture, shear and friction. This reduces mechanical forces on the skin and maceration that increases breakdown risk. 5. Optimize protein energy intake and document staging, escalation according to local policy. This supports tissue healing and ensures timely communication and management of pressure injuries. Thromboembolism and bleeding balance. 1. Assess beat risk and bleeding risk on admission and daily. This allows balancing prevention of clots against bleeding as both risks change during critical illness. 2. Use pharmacologic prophylaxis when not contraindicated, mechanical prophylaxis when appropriate. This reduces beat incidence while providing an alternative when anticoagulation is unsafe. 3. Ensure correct dosing in renal dysfunction, obesity, thrombocytopenia and extremes of body weight. This is because standards may be ineffective or cause bleeding in these groups. 4. Reassess around procedures, neuraxial techniques, active bleeding and severe coagulopathy. This prevents bleeding complications by timing prophylaxis interruption appropriately. 5. Mobilization. Additional protective strategy, not a substitute for indicated prophylaxis. This is because early mobilization alone does not provide sufficient protection against VT. Glycemia, lines and medication safety. 1. Avoid both severe hyperglycemia and hypoglycemia. Use a protocol with frequent reassessment. This prevents harm from both extremes, as both hyperglycemia and hypoglycemia worsen ICU outcomes. 2. Perform medication reconciliation and renal, hepatic dose adjustment. This ensures home medications are correctly continued or held and prevents toxicity from impaired clearance. 3. Use independent checks for high-alert infusions, concentrations and pump programming. This reduces medication errors, as high-alert drugs have a high risk of harm if miscalculated. 4. Review stress ulcer prophylaxis indication. Stop when risk resolves. This balances protection against stress-related bleeding while avoiding unnecessary prolonged prophylaxis. 5. Prevent constipation and urinary retention with an individualized bowel-bladder plan. This avoids secondary complications, discomfort and agitation that prolong ICU stay. Transitions and post-ICU complications. 1. Communicate baseline function, ICU course, devices, delirium, mobility and nutrition at transfer. This ensures continuity of care and prevents information loss during handover from ICU to the ward. 2. Screen for persistent cognitive, psychological, sleep, pain and physical problems. This allows early identification of post-intensive care syndrome and its related complications. 3. Give patients and families a clear recovery plan and warning signs. This improves understanding, adherence and early help seeking if deterioration occurs. 4. Arrange rehabilitation, medication review and follow-up according to local resources. This supports ongoing recovery and prevents medication errors after critical illness. 5. Include ICU diaries or structured debriefing where available and appropriate. This helps patients make sense of their ICU experience and reduces psychological distress. Implementation. Make prevention reliable. 1. Standardize protocols, order sets, bedside prompts and escalation criteria. This reduces variation in care and ensures preventive measures are applied consistently. 2. Educate, simulation, competency checks and visible role modeling. This builds knowledge and skills, and reinforces best practice through leadership example. 3. Measure, process adherence and patient outcomes. Stratify by unit, shift and patient group. This allows tracking of prevalence and identification of gaps in specific areas. 4. Learn, review infections, pressure injuries, unplanned extubations and delirium cases without blame. This promotes a just culture where system issues can be identified and corrected. 5. Improve, test small changes, share run charts and close the feedback loop. This drives continuous improvement by making progress visible and acting on data. Suggested ICU dashboard. 1. CLABSI and CAUTI per 1,000 device days. This provides standardized infection rates that allow tracking of trends and comparison over time. 2. VAP metrics according to the surveillance definition used locally. This ensures ventilator-related events are measured consistently using the locally adopted criteria. 3. Hand hygiene and insertion bundle compliance. This monitors adherence to core preventive practices that directly reduce healthcare-associated infections. 4. Daily device removal, SAT-SBT, delirium assessment and mobility completion. This tracks completion of daily care bundle elements that shorten device days and improve outcomes. 5. Pressure injuries, unplanned extubation, ICU-acquired weakness and ICU mortality. This captures key patient harm and outcome measures related to ICU-acquired complications. 6. Balance measures. Falls, accidental line removal, hypoglycemia and bleeding. This monitors unintended consequences to ensure improvement in one area does not cause harm in another. Case application. First 24 hours. Patient. Mechanically ventilated septic shock with a central line, urinary catheter, deep sedation and poor intake. Immediate priorities. Stabilize perfusion and oxygenation. Confirm indications for every dose. Initiate infection prevention bundle. Within the next cycle. Analgesia first sedation target. Delirium screen when accessible. SAT, SBT readiness. Head-up positioning and oral care. Start nutrition when hemodynamically appropriate. Inspects device sites. Assess feed and pressure injury risk. Document one owner and one measurable target for each action. Conclusion. What we do in the first 24 hours determines whether devices help or harm. Prevent complications from day one, so the patient leaves the ICU without a preventable injury. Take-home checklist. 1. Prevent first. Avoid unnecessary invasive devices and deep sedation. This reduces exposure to the main risk factors for healthcare-associated infections and complications. 2. Use reliable bundles. Hand hygiene, COTI, ventilator liberation and skin care. This ensures consistent, evidence-based prevention of device-related and pressure-related harm. 3. Assess daily. Pain, sedation, delirium, mobility, nutrition, VEAT and device necessity. This allows early identification of changing needs and prompts timely removal of unnecessary devices. 4. Mobilize and orient early. Protect sleep and sensory function. This reduces delirium, deconditioning and functional decline during critical illness. 5. Measure matters. Learn from harm and involve families. This drives accountability, continuous improvement and shared decision-making. 6. Adapt recommendations to local policies, resources, patient age, diagnosis and contraindications. This ensures recommendations remain safe, feasible and appropriate for each patient and setting. Thank you for watching. If you liked this content, don't forget to like to show your support. Comment and share your thoughts. Share with your friends and family. Subscribe for more exciting content. Your engagement means the world to us. Stay tuned for more.